Good morning. Thank you for that introduction. Today I get to talk to you about pain in MS, which I think is a very important topic and frankly one that we don't get to talk about often enough. Our objectives for today will be first to learn about neurological pain pathways, understand a little bit about the impact of pain on quality of life in MS, describe different sources of pain in MS, and finally, we're going to review some treatment options for pain in MS. Oh, I don't have a disclosure slide, but I don't have any relevant disclosures for today's talk. Because we're neurologists, we often like to think in terms of structures and pathways. And so I put this slide in here to kind of demonstrate how pain gets transmitted in the body, where, regardless of the source of the pain, this can be from a burst appendix or a fractured bone, as I had the pleasure of doing a couple months ago to this wrist. You end up starting with the pain signal going from a specialized pain receptor out in the periphery, typically, and that'll get transmitted via the first order sensory neuron, which has its cell body kind of just outside of the spinal cord over here, which is not depicted in this image, but in a collection of cells called the dorsal root ganglion. And then from there, the projections go in through the dorsal root entry zone here in the back of the spinal cord into the spinal cord itself. So just so you're aware, this is a cross section of the spinal cord. On the outside, you have the white matter, and on the inside, you have the gray matter. So it's a little bit opposite what we see in the brain. And those first order neurons contain fibers. For pain, those fibers tend to be small caliber, thinly myelinated, what are called A delta fibers, and then also unmyelinated C fibers. And for those who are keeping track, this is basically the same myelin substance as in the central nervous system, but from a different, produced not by oligodendrocytes, but by these cells called Schwann cells. And so then you get into the spinal cord, and you're connecting or synapsing with second order neurons here in the dorsal horn, particularly in lamina 1 and lamina 2. And then those second order sensory neurons are then crossing over to the other side of the spinal cord and then ascending in these pathways. We have the main kind of spinothalamic pathway, as well as the spino-reticular pathway that ascend vertically through the rest of the spinal cord into the lower part of the brain. The brain stem, in the case of the spino-reticular pathway, and the spinothalamic pathway, as the name suggests, goes from the spine to the thalamus here, which is kind of the central way station for all sensory information coming into the brain. The spinal-reticular pathway is also important for, and we'll get into this in a little bit, the more kind of affective or emotional elements of pain. And so for kind of simplistically, a lot of us like to think, okay, pain is this process that goes one way. It comes from the periphery to the kind of central headquarters, or just kind of ascends. But in fact, there's also a descending pathway, which is actually quite important. A lot of these same structures here, particularly here in the thalamus, the amygdala, and then in the brainstem, the periaqueductal gray, the rostral ventral medulla. These kind of feed back downward into the spinal cord here and connect with what are called interneurons. These are neurons that produce inhibitory chemical messengers like GABA and glycine, and those end up modulating, either increasing or decreasing the intensity of the pain signal, which is actually quite important. So that brings us to some common kind of concepts in pain, including sensitization and modulation. So with sensitization, you can have a situation where with repeated noxious stimuli, you end up lowering the threshold for these pain receptors to the point that sometimes you can have this situation where even just like a light touch, just a very gentle thing, which is normally not harmful, but in fact produces pain. And we can see this sometimes with things like trigeminal neuralgia. We also know that the sympathetic nervous system, the so-called fight or flight pathway, when it's revved up, that can also heighten pain sensation. It's kind of what I was referring to before with some of that more emotional part of, or in this case, physiologic part of pain pathway. So, evolutionarily, that might be advantageous. So, you can remove your hand from the flame or your head out of the lion's mouth. But these days, it kind of ends up oftentimes being more detrimental by increasing pain signals. And then, as I mentioned above, you have these descending pathways, notably coming from the midbrain, the medulla in the brainstem, and projecting downward into the spinal cord onto those interneurons using chemical messengers like serotonin and norepinephrine to kind of dampen or lessen pain. And that can be exploited also pharmacologically, which are in some ways that I can get to later on. Which brings us to also the gate control theory of pain. This is via those inhibitory interneurons in the dorsal horn, which I mentioned. The idea being, if you kind of present this repeated non-noxious stimulus, it can kind of distract your body into not being in as much pain. And so this is kind of like what we do unconsciously after banging into something, where we kind of rub that area, and it's also probably what gets exploited for things like a TENS unit, or for like spinal stimulation, which I'll discuss a little bit later. So to kind of sum up, then, we know that there are factors that can either increase or decrease pain signals, much of which can be under your control, or you can make it more or less under your control. Things that increase would include like stress, anxiety, whether you pay or you're actually like paying attention to the pain, and then things that produce fear or uncertainty about kind of how long the pain is going to exist. All of that can increase your pain. And then conversely, being relaxed, being in a kind of state of more contentment, focusing on something other than the pain, especially through things like meditation. And you'll hear about meditation and other non-pharmacological type approaches more in the next talk with Dr. Corboy. But those are all things. And then, of course, because we're doctors, we prescribe medications. These are all things that could potentially decrease pain. Pain has an impact on the quality of life in MS. We know that it is a complex process involving biological, psychological, and social factors. That it is incredibly common, and it can affect between 1/2 and 2/3 of people with MS, which I've still run into patients sometimes who tell me that they've heard that pain doesn't exist in MS, which I find frankly very surprising. If anybody has ever actually taken care of somebody with MS, to think that it's not, that there's no pain in the condition. We know that pain can affect nearly every aspect of a person's life, can lead to worsened physical functioning, worsened sleep, worsened mental health, lost productivity, more doctor's visits, higher health costs. And this is kind of a handy diagram that I borrowed from a former colleague. You can see here in the upper left-hand corner, this is kind of what we think of as nerve pain or neuropathic pain that are common in MS, such as trigeminal neuralgia, paroxysmal sensory symptoms or tonic spasms, or Lermite sign, which is that phenomenon where you flex your neck forward and there's an electrical sensation that shoots down the spinal cord. The nerve pain characteristically is not responding to a specific stimulus, and it's kind of because some part of the nerve pathway responsible for pain is damaged, the signal just kind of goes by itself. And so we'll get into some of these particular examples later on. Pain can also result, though, kind of indirectly or secondarily from other MS symptoms, most notably from spasticity. So that's another common symptom we'll talk about in a bit. But if somebody is very spastic in a limb, that can cause pain where the pain receptors are kind of responding appropriately because it's an uncomfortable position, especially if somebody has a very contracted limb, or for instance, if they're very immobile, and they can get pressure ulcers or other things because of the MS, but those ulcers then can be quite painful. Or alternatively, you can get visceral pain, like say, for instance, somebody has MS-associated constipation that could potentially be painful. Sometimes treatments can cause pain. So MS treatments, especially some of the older injectable medications like interferon beta, glatiramer acetate. We can hear about people who are getting, like, for instance, pain at the site of injection kind of thing. And then finally, you can have pain that's unrelated to MS. And some of you have heard me talk about this concept before, that just because somebody has MS doesn't mean that all of their symptoms are related to MS. And so take, for instance, back pain or headaches. Some of these things are extraordinarily common just in the general population. And so even if you have MS and you're experiencing one of these things, it doesn't necessarily mean that MS is the cause. And then also we have these peripheral neuropathies. And just kind of for definitional purposes, when we talk about neuropathy, we neurologists mean a problem in the peripheral nervous system, that first order kind of sensory pathway, which in MS, because it's a disorder of the central nervous system, but by definition, it's not going to include peripheral neuropathy. There can be nerve pain or neuropathic pain, but it wouldn't be peripheral neuropathy. Another way of subdividing pain would be simply, defining it as whether it's acute or chronic. So certain things like trigeminal neuralgia, the Lermite phenomenon that I described, or MS hug, where you get this kind of tightening or corset-like sensation around the midsection, or the kind of tonic spasms. Those things are all acute. They may occur in clusters or recurrently, but the actual pain itself tends to be very acute, versus something that's more chronic, the kind of dysesthesias, numbness, tingling, burning of the limbs, or itching that may be kind of there all the time, sometimes better, maybe sometimes a little bit worse, maybe, but it's kind of there all the time. So that's another way of kind of subdividing pain in MS. We know that sometimes pain is a marker of a inflammatory activity, like, for instance, if somebody's having eye pain with loss of vision, that could indicate a relapse, for instance, optic neuritis. Sorry about that. Although also you could just be experiencing an increase or an uptick in pain in a familiar area around the time of increased heat, stress, trauma, or infection, something we would term pseudo exacerbation or a pseudo relapse. Some of you have also heard me talk about this concept as well. I do want to point out that just because somebody gets steroids and it actually improves the pain symptom doesn't necessarily mean that it's a relapse, just because we know steroids are potent anti-inflammatory and potent painkillers. So that doesn't necessarily help us to determine whether it's one or the other. MRIs, of course, can sometimes be helpful in that process. So let's delve into some of the specific areas of pain. So this would be trigeminal neuralgia, which is characterized by a stabbing or severe pain in the face and the jaw. You can see here, this is the distribution of the trigeminal nerve, which supplies sensation to the face and the kind of lower scalp area and into the jaw here too. And it's further subdivided into three regions: the ophthalmic zone, maxillary zone, and mandibular zone, so-called V1, V2, V3. Trigeminal neuralgia, which is a common symptom in MS, but we can also see it sometimes independent of MS, tends to be more of these kind of lower branches of the trigeminal nerve, V1, V2, V2, V3. And it can be triggered by eating, by brushing teeth, by speaking, and characteristically, it comes and goes, it's intermittent, and it can come on unpredictably. There are treatments for trigeminal neuralgia, including our first line. We would tend to reach for a medicine like carbamazepine or oxcarbazepine. All of these medicines were originally designed as anti-seizure medicines, but we use them extensively for these purposes too. Other options would include lamotrigine, lacosamide, topiramate, gabapentin. And I'll note that there's no one size fits all really for any of these kinds of treatments, and oftentimes we end up prescribing something, and maybe it provides some benefit, but maybe not enough benefit. So it's important to kind of circle back with the provider and making sure you're kind of tweaking the medication to get the right dose for you, and not just kind of giving up when it doesn't work instantaneously. And then for more difficult cases, there's also the option to kind of go directly to lesioning or damaging the trigeminal nerve therapeutically, for instance, with a balloon or radiofrequency rhizotomy. The kind of treatment for classical trigeminal neuralgia involves microvascular decompression. That's when we do an MRI with thin cuts through the lower part of the brain, and we see that there's a little blood vessel that's kind of coming into contact with the trigeminal nerve, and then a surgeon can then go in there and kind of decompress that vessel away from the nerve, which is not done as commonly anymore. And these days, oftentimes the surgeons will go towards gamma knife for refractory cases of trigeminal neuralgia. This is a type of radiosurgery which can actually be quite helpful, but the effect generally tends to come on several weeks after the procedure, and sometimes there can be recurrence, and so some patients have had to do the gamma knife multiple times. I threw this slide in here about migraines and MS because I'll sometimes get asked about it, and I looked through the literature. There are some articles that report increased prevalence among MS patients, but it's really tricky because there's, this is, again, something that's incredibly common in the general population. And more often than not, we tend to treat it similarly, whether the person has MS or doesn't have MS. And just more broadly speaking, we're looking for other things if somebody is suffering from headaches on a regular basis that can be triggering or contributing to their headache frequency. So for instance, if it's a side effect of a medication, with MS medications, we can sometimes see headaches or flu-like symptoms with interferon beta products, and headaches are also a common side effect of fingolimod. But then also there are other medical issues. For instance, if somebody has a sleep disorder such as obstructive sleep apnea, which can also, is quite common in MS populations and can increase headache frequency. We try to address those or find somebody who can address those issues, and that kind of can help us reduce headache frequency. But oftentimes, if it's a challenging case and there's a lot of headaches, yes, we are neurologists, but we do sometimes lean on our friends and colleagues who have expertise in headache for sometimes more advanced treatment options, for instance, Botox or nerve blocks. Oh, this is going a lot faster than I thought it would. Just have a few more slides. So spasticity, I'll try to move fast. This involves a feeling of stiffness or involuntary muscle contractions. It is very common in MS and other neurological disorders. And as I mentioned before, it can produce tightness in and around the joints, which can be painful. And that can fluctuate depending on a variety of things, including activity level, energy level, infections, and so forth. And we'll use a variety of different medications that you see here to try to address it. Sometimes also physical and occupational therapy. And then in severe cases, we can refer for Botox, again, botulinum toxin injections, which is a powerful paralytic. And then sometimes also the kind of intrathecal baclofen pumps where you get kind of a hockey puck kind of thing implanted in your abdomen, and then the catheter gets snaked into the spinal cord and delivers baclofen directly that way. Both of those are kind of used for more severe cases, and so we don't always go right to them. Dysesthesias of the limbs, this is kind of the common thing that people think about when they think about nerve pain. This is just that kind of uncomfortable burning, tingling, itchy, prickly electrical or cold sensations, usually in the legs and feet more than the arms and hands, but it can be anywhere. And these might linger, often independent of relapses. Again, sometimes better, sometimes worse, depending on certain things. Some people report that it's worse at nighttime. We do have, again, a variety of different treatment options, including what you see listed here: gabapentin, pregabalin, venlafaxine, duloxetine being kind of go-to for me. And there's also topical medications. We have, in addition, and I'll mention this briefly at the end, there's CBD and THC preparations, which we can kind of get into, which come in different kind of flavors like oral or topical. And then the non-pharmacological approaches like that Dr. Corboyle mentioned, including hopefully acupuncture, mindfulness, meditation. When the pain gets very severe and it's not responding to our traditional medications, which doesn't happen often, in fact, not in the majority of cases, but occasionally it does, those folks will often benefit from a multimodal and multidisciplinary approach involving the neurologist, but also a pain specialist, mental health professional. Sometimes we'll refer for implantation of a spinal cord stimulator, which I mentioned before, and the basis of which might be that kind of gate control theory of pain. Memantine, and then cannabinoids and opioids, which I think I just have a couple more slides. So as far as cannabinoids go, and I think there's a question about this also, so maybe I can save some of this for the end, but we know that there are cannabis receptors cannabinoid receptors, I should say, that kind of distributed in a lot of those areas that we mentioned as being relevant for pain, including the cortex, thalamus, periaqueductal gray, and then in the spinal cord here. And it's hypothesized that perhaps some people with chronic pain might be experiencing that because that system is imbalanced. I think we don't know that. We know that cannabis use is widespread among MS patients. We know this from surveys, including from some of our colleagues, including Dr. Alvarez, Dr. Nair, and some patients find it helpful for insomnia, spasticity, and pain. It has been somewhat difficult to study up till now, owing to the legal status. Also, there are different strains, and kind of not kind of standardization production techniques. There's also like just a lot of chemicals involved in the cannabis, so it can be very difficult to study scientifically. And I think we sometimes forget this, but there is also a potential for abuse, and there can be some side effects. This is my final slide. And this is kind of top of mind too, because, well, we're still kind of in the midst of this massive opioid epidemic in this country, and we as providers have to undergo this kind of periodic courses to talk about appropriate use of opioids. And I put this slide in referring to specifically kind of people who are suffering from kind of chronic or subacute pain that's going on for longer than a month or 3 months. And here, the recommendation really should be to reach for non-opioid therapeutics first, and then also maximize use of non-pharmacologic approaches. And then if you are going to try an opioid, you really have to be aware, the patient and the provider has to be aware of the risks and benefits, and there should really be some kind of plan to work out for assessing how to measure its effectiveness, and most importantly, kind of, if it's not effective or if it becomes risky in some way, how do we stop that? And so to conclude, pain is very common in MS. It can arise from damage to a relevant pain pathway, in which case we would get nerve pain, or secondarily from spasticity or other chronic MS issue, or potentially from a medication side effect, or could be just unrelated to MS. There are treatments, including many that don't have abuse potential available, but unless you tell us that this is what's going on, we don't necessarily know, and we can't address it. So that's kind of the important element. And so we may end up relying on or working collaboratively with other specialists, including pain specialists, therapists, and mental health providers. So thank you for your attention, and I look forward to answering some of your questions in the Q&A session.